I'll just do a quick recap. Diabetes insipidus, the problem is excessive loss of water. Always picture the cartoon saying that I'm dry inside, and I need more water. And it's because the individual is peeing too much. And the reasons being that there is decreased secretion of the hormone, antidiuretic hormone, from the posterior pituitary. And antidiuretic hormone is telling you to hold on to your water. So if you have decreased secretion of antidiuretic hormone, it means that you're just going to give away too much water. And that means that the client will be dehydrated. The second reason being that the kidneys are not able to respond to ADH being produced. So in that case, the kidney is not getting that signal to hold on to water. So the client will be peeing a lot and will become dehydrated. So always know that diabetes insipidus is a problem with ADH, whereby the body will be unable to hold on to water, and there will be excess loss of water by urination. And do not let the word diabetes confuse you. As I said, diabetes means putting out a lot of water. And with insipidus, the client is giving out clear, colorless, tasteless urine. So simply put, diabetes insipidus means water diabetes, because the client is giving out too little ADH, and so will pee a lot, and that will lead to severe dehydration. And as a safe NCLEX nurse, remember that anytime you have a client with diabetes insipidus, look out for severe dehydration. So the client will be very thirsty, there'll be decreased skin tegel, there'll be dry mucous membranes. And yes, know the typical presentation. Increased urine output. Imagine about 30 liters a day. Client is so thirsty. And decreased intravascular volume will lead to blood pressure being low. And then the body, in compensating for that, the heart rate will increase. So do not let the word diabetes confuse you. There is no hypoglycemia in diabetes insipidus. Dehydration should always be on top of the effect that a client with diabetes insipidus would have. So let's now continue. Three main causes of diabetes insipidus. It can be neurogenic. When you hear neuro means brain. So neurogenic means it's coming from the brain, and it's as a result of insufficient ADH being produced by the brain, specifically the posterior pituitary gland. Number 2, it can be nephrogenic. Nephro means kidney. Nephro means kidney. So the kidneys are unable to respond to the ADH being produced. So for nephrogenic diabetes insipidus, ADH has been produced, but the kidney is not responding to the ADH that has been produced. So in that case, the kidney will not hold on to water, and the client will just be giving out too much urine. And number 3, it can be as a result of medications. Some medications have side effects. Lithium and demiclocycline, they can induce diabetes insipidus. So they can cause the kidneys and alter the response to ADH. So if you're an NCLEX nurse and you've got to be a safe nurse, you have a client on the ward, has recently been put on lithium or demiclocycline, and clients now begins to pee so much, getting dehydrated, you should be able to connect the two, that it is because lithium has that side effect. So let's now go to how to differentiate between primary and secondary diabetes insipidus. So when for primary diabetes insipidus is coming from the brain. So it's an inherited or idiopathic malfunction of the posterior pituitary gland. So we have the posterior pituitary gland producing ADH. So when there's the problem with the main center, that is the brain, then it is called primary diabetes insipidus. But for secondary, it could be as a result of tumors. So we have something else affecting the effect of ADH production. So we have tumors. Somebody has been involved in head trauma, and as a result of that, the person now develops secondary diabetes insipidus. Infection, stroke, cerebral aneurysm, or surgery, which is at the area of the pituitary or near the pituitary. So the person underwent a surgery, and then it was maybe a pituitary surgery, so it had an effect on the posterior pituitary, and later on the client presents with symptoms of diabetes insipidus. That is secondary. So I hope you got the difference, primary and secondary. So this is to help put the posterior pituitary in perspective. So this is the anterior part of the pituitary, and this is the posterior pituitary, which produces the antidiuretic hormone. So let's dive more into clinic. So how would you as a nurse assess your client who comes with diabetes insipidus? It's very important to know about the history. You see, we went through some of the causes, the secondary causes. So we have to know whether this client has had any head injury, any brain surgery, any infections to the brain, or any tumors. And you remember that some medications have side effects presenting as diabetes insipidus. So you have to do a medication history, know about the past medications that the client has been on and the present medications. It's important that we assess the level of consciousness, because the client can lose a lot of water, and then there will be altered sensorium. And yes, as the client is losing so much water, the blood pressure will drop. So you cannot have a client with diabetes insipidus and you wouldn't check the blood pressure. That is disastrous. So check client's blood pressure, including orthostatic readings. That is taking the blood pressure of the client lying down and taking the blood pressure of the client sitting up. And as the client is losing so much water, we have to assess for dehydration. And one of the ways we assess for dehydration is to check the skin turgor. So check the skin turgor, assess the fluid. Is the client giving out enough urine? And is the client taking in enough? Because the client is losing a lot of water. And then we check the client's weight. It is very important that we check the client's weight. And then the skin integrity. Polydipsia. Is the client excessively thirsty? Because client is giving out too much urine. So the client will surely be very thirsty. Look for skin tenting, check bowel sounds, and assess for constipation. So one may be asking, what labs will be relevant? What labs will be relevant for our client with diabetes insipidus? Urine-specific gravity. You must know that, because the client is peeing a lot, drinking a lot. So the client will give out very dilute urine. So when you have urine that is so dilute, the specific gravity, the gravity will be very low. So we have specific gravity, so know this value being less than 1.005. So know that with diabetes insipidus, the specific gravity of the urine will be very low because client is producing too much urine, so it's just too dilute, and so the specific gravity will be very low. And the same with osmolality. Too much urine being produced, so the osmolality will be very low. So it's going to be less than 300 milliosmol per kg. So know your values. And there will be a positive water deprivation test. We deprive the client of water to see if the client will be able to concentrate the urine. And as we already said, there will be reduced ADH production. And that will be in the case of primary diabetes insipidus, where the problem is coming from the brain, the top center. So it's coming from the main center. There's an issue with the posterior pituitary, and so there will be decreased ADH production. And as the client is giving out too much urine, too much dilute urine, there will be serum sodium going up in the blood. So there will be hypernatremia. So when we take the blood sample, we're going to get serum sodium being more than 145 milliequivalent per liter. So note this. Client is giving out a lot of dilute urine, but in the blood, the client is going to have high sodium, that is hypernatremia. And this is the value: serum sodium more than 145 milliequivalent per liter. So know your values. Low urine specific gravity, less than 1.005. Urine osmolality, that is very dilute urine, so less than 300 milliosmol per kg. And the positive water deprivation test, then reduced serum ADH in case of a primary diabetes insipidus. And note, for diabetes insipidus, there would be hypernatremia, high sodium in the blood. So serum sodium, when we take the blood sample of the client for the lab, we're going to get serum sodium more than 145 milliequivalent per liter. And note this, that urine will be negative for sugar. As I said, the fact that there is the word diabetes here doesn't mean that clients with diabetes insipidus has hyperglycemia. So urine will be negative for sugar. And note that for ketones, it is also going to be normal. So do not get confused anytime you see a question testing you on the lab picture that you're going to have for a client with diabetes insipidus. So let's now dive into therapeutic management of a patient with diabetes. So yes, let's continue with therapeutic management of a patient with diabetes insipidus. So number one, water replacement orally. So you have this client, you picture the cartoon telling you, I'm dry inside, I'm dry inside, I'm dry inside. In that case, what should happen? That client is supposed to be given more water. Okay, so that client is supposed to be given more water. So water replacement orally, and sometimes intravenous dextrose is given as needed to help normalize the lab values. So the client is dry inside, diabetes insipidus, dry inside, so give the client water. And for neurogenic diabetes insipidus, neurogenic, which means is coming from the brain. It's coming from the brain. So it means that the brain is not producing ADH. There is problem with the posterior pituitary, so we do not have ADH. So in that case, We have to give artificial ADH. Client doesn't have ADH, so we give synthetic vasopressin. So there is hormone replacement with desmopressin. Number 3, other medications can also be given. We have clopropamide, carbamazepine, and these medications, they've been known to help increase ADH release and also to enhance the effect of ADH on the renal collecting duct. So it will help the duct, it presses the duct so that the duct will do what? Keep water for the individual instead of just losing water. Number 4, for nephrogenic. So nephrogenic as a result of the kidney. So for nephrogenic diabetes insipidus, we have to do what? Correct the underlying disease. So whichever disease is causing it has to be corrected. And we stop the causative medication in case the client is on any medication that is inducing the diabetes insipidus. We have to stop that medication. And then by way of diet, low salt diet and low protein diet. So take note of this. And if you have any clients, you losing a lot of fluids, to be a safe nurse, we've got to monitor the input and output every hour. And if the urine output is more than 200 ml per hour or more than 500 ml over 2 hours, we have to report to the attending physician. And it's important that we assess for continence, because what if this client is incontinent with urine? That's why they're giving out a lot of water. So we have to rule out any form of incontinence. So assess for continence. And since this client is visiting the washroom several times, this is very key. Otherwise, your client will be mad at you. You have to provide easy access to the bathroom. Provide easy access to the bathroom, and you weigh the client daily because client is losing a lot of fluids and is becoming so dry. So for us to be able to monitor our management, we have to do the daily weight to be sure that this client is not losing so much per day. And if there is significant weight loss, as a safe nurse, report to the physician. And remember, we spoke about urine specific gravity being very low because the urine is so dilute, so specific gravity will also be very low. So we've got to monitor urine specific gravity. And if it's becoming too low, it means that client is producing a lot of dilute urine, alert the physician of the specific gravity decrease. And you remember, we spoke about serum osmolality, which will be also low, and we also spoke about sodium. So the urine osmolality will be low, but for blood, the serum osmolality will be high, the sodium in the blood will be high. So for diabetes insipidus, the serum, the blood, the osmolality is going to be high, and then the sodium in the blood is going to be high. So you're going to have hypernatremia. And yes, encourage fluid intake to be greater than the urine output. Otherwise, clients will become dehydrated. And provide fluids within reach at all times. Client is dry inside and saying that I need more water to drink. So you have to make sure there is water available. Provide IV fluid replacement as ordered. And then use skin protective barrier with incontinence. In case there is incontinence, use skin protective barriers. And yes, we have to also provide some relief for clients from the polydipsia. They are drinking so much. So nasal desmopressin spray can be given, and it provides relief from polydipsia and control of polyuria and nocturia in the client, because client is peeing a lot, so we're going to give out a lot of urine. That is polyuria, and because they're giving out a lot of urine at night too, they're going to also pee a lot, and that is nocturia. And note the side effects of nasal desmopressin. There will be nasal congestion and some headaches. So if you have a client with diabetes insipidus, has been put on nasal desmopressin spray recently, and then clients come with nasal decongestion and headache, you should be able to link the two. I hope you are with me. Can somebody give me the side effect of nasal desmopressin? I want to be sure that you were paying attention. You can type in the chat box. Side effect of nasal desmopressin. Side effect, nasal congestion. Great, blessing. Great. Another one, the second one. Can someone give us the second one? I want to be sure that you are paying attention. What's the second side effect? You have your client on the ward with nasal desmopressin. Okay, great. Thank you so much, Mercy. Headache. So nasal congestion and headache. So for NCLEX, the nursing teaching is a priority. So what teaching are you going to give to your client? What teaching are you going to give to your client? So we have to provide information about diabetes insipidus. The client may not be aware of all that diabetes insipidus entails. We provide teaching about self-administration of the medication that will be given, and you have to let them know for the possible need for lifelong medication. We encourage the client to wear a medic alert bracelet and list diabetes insipidus and its treatment. We have to encourage the client to drink fluid equal to the amount of the urine output, because if they are giving out a lot of urine and they are not drinking enough, the client is going to be dehydrated. So encourage clients to drink fluids. And then they would have to keep a log of their ins and their outs, what they're taking in and the amount of urine that is given out every day. And they would have to continue with this self-weighing that is daily on the same scale at the same time of the day, and have to keep that record and report any weight loss. And then clients should consult the practitioner before taking any over-the-counter medications. This is very important. Client has to consult the medical practitioner before taking any over-the-counter medications. What if the medication that the client is going to take has a side effect of inducing diabetes insipidus? That will be disastrous for the client. So this last point is very important. So now, let's try some few questions. I'll be dropping the link for the mock exam. We've structured some wonderful questions to help test your knowledge. And I would entreat each and every one of you to partake in the mock exam when I drop the link. It will help you to test your knowledge on all that you've learned today, so that when you meet any question on diabetes insipidus, you will be able to answer it. So please, 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 today, everybody should attempt the mock right after I drop the link. So, can somebody volunteer to read this question for me?
The nurse is caring for a client diagnosed with diabetes insipidus. Which interventions should be implemented? Select all that apply. 1. Restrict fluid intake to no more than 1,000 ml per day. 2. Administer DDAVM, AVP, and antidiuretic hormone. 3. Assess the client for signs of water intoxication. 4. Place the client on seizure precautions. 5. Check the client's urine specific gravity.
Great.
All right.
So select your answers. You can also type their answers into the chat box. But Blessing, can we hear your answers?
I would say check the client's urine specific gravity.
Great.
Assess the intoxication.
Okay.
Administer EDAVP and antidiuretic hormone.
Great.
Assess
Great.
the client for, yeah.
Great.
Place the client on seizure precautions.
Yes. Well done, well done, well done, well done, Blessing. So let's look at the answers. So yes, administer desmopressin, which is an antidiuretic hormone. Assess the client for signs of water intoxication, and then check the client's urine specific gravity. So these are the correct answers. Number 1, restrict fluid intake. No, client is losing a lot, client is dry inside, and so client is supposed to take more water. So let's read the teaching point. So Blessing, you can read the teaching point.
So the treatment for diabetes insipidus is hormone replacement with DDAVP, desmopressin, and assessment for signs of hyponatremia, water intoxication, weight gain, and headache, which indicate the medication is not effective. Interventions for syndrome of inappropriate antidiuretic hormone include restrictive fluids and seizure precautions.
Great. So the other wrong answers were for SIADH, which is more like a rival of diabetes insipidus. You dive a bit into it before we end our session, so you can understand that a bit. Okay, so I think I have that over here. So let's summarize diabetes insipidus. I would want you to understand it so well that any question that you will meet on diabetes insipidus, you will be able to answer. So you see diabetes insipidus, DI. So immediately you see diabetes insipidus, as I said, picture the cartoon saying DI, I'm dry inside. I'm so dry inside. I'm peeing a lot. My urine is so dilute. And so I need more water to drink. My blood pressure is decreasing. I'm dying. My skin is so dry. And the sodium in my blood is increasing because I'm losing so much urine. Remember, dry inside, and that will guide you. And this mnemonic with the 7 Ds will also be of help. So 7 Ds, diuresis, so high urine output, you're giving out a lot of urine. The second D, diluted urine, so the urine specific gravity will be very low, so that is D number 2. D number 3, as I said, dry inside, so high and dry labs. Remember I said for the blood, there will be hyperosmolality. The osmolality will be high. This is an NCLEX tip. Do not let it confuse you. For the blood, for a client with diabetes insipidus, the osmolality will be high and the sodium will be high. more than 145 milliequivalent per liter. Then D number 4, client is drinking a lot because client is very thirsty. D number 5, client is very dehydrated, so dry mucosa, dry skin. D number 6, decreased blood pressure. You are peeing a lot, decrease intravascular volume, so your blood pressure is going to be low. And D number 7 is the drug that we give to control diabetes insipidus, and that is desmopressin, vasopressin. It is artificial ADH. Artificial ADH. You are not producing ADH, so we have to give it to you artificially. And as the name implies, desmopressin, vasopressin, more like it's going to work on the kidney tubules. It's going to press on them, that retain your urine, keep your urine. You are giving out too much water. Press on the tubules and help retain the urine. So in that case, there would be decreased urine output. So this is very important. This is very important, and you must take note. You see diabetes insipidus, dry inside, start to recount the 7 Ds. And one important thing you would have to go and revise would be the rival, the opposite of diabetes insipidus, that is SIADH. When you see SIADH, just picture a ballooned individual saying that so as diabetes insipidus is dry inside, for SIADH, the SI soaked inside. The individual is soaked inside with so much water and ballooned. So it's more like the opposite of diabetes insipidus. So that individual is producing low amount of urine. That individual has too much ADH. So if you have too much ADH, what will happen? ADH tells you to keep your urine. So if you have too much ADH, what will happen? You're going to keep all your water. So the client will become soaked inside and ballooned. So just picture this cartoon here, soaked inside and ballooned. So instead of client peeing a lot in diabetes insipidus, for SIADH, low amount of urine. The client is so stingy and keeping all the urine. So do well to revise SIADH because it is also a high yield for NCLEX. So that will be your homework, your learning point for the homework. You have to go revise and know the differences between diabetes insipidus and SIADH.